Was it on?
It was muted.
So nobody heard me?
No.
Should I step back a minute?
No, they said, good, go now.
Okay. So I actually do want to step back. If I can go back just a minute, because we did have everybody miss the land acknowledgement. So again, we're here present in Prince George on the unceded territory of Clay-Clay-Tenay, and just wherever you may be joining us from today, you can acknowledge that in the chat if you would like. So this is our organizing committee, Annie, myself, and Cameron, as well as Lena and Bree and all the wonderful work that they do with the HRI and keeping us organized. Just for you guys to note, this is our upcoming schedule. So next month we have Anurag Singh join us, who is the new director of the Northern Center for Clinical Research. So please keep in mind, all of our past seminars are posted on the website, and you can also find the schedule for the upcoming seminars there as well. And so, because health research is multidisciplinary, these are our contributors and sponsors: the School of Health Sciences, School of Nursing, School of Social Work, Psychology, Northern Medical Program, and of course, Sun Life Financial. So as I mentioned in my first introduction, this seminar is being jointly hosted by the School of Nursing. And now I am going to call up Sarah Dewell, who is going to introduce our speaker for today. All right. Oh. On the, yeah, okay. All right. Hi, everyone. I'm Sarah Dewell, and I'm in the School of Nursing here at UMBC, and I'm just thrilled to introduce my colleague, Dr. Gigi Lim. Gigi is a senior lecturer above the bar at the University of Auckland School of Nursing. Her teaching covers undergraduate, but mainly at the postgraduate levels, where she is actively involved in the development of courses, notably related to pharmacology and in the preparation of nurses for prescribing. The School of Nursing was the first in New Zealand to develop courses to prepare nurses for prescriber roles, and is regarded as a pioneer in the educational preparation of non-medical prescribing. She has been recognized internationally for her teaching and has been awarded the Excellence in Genomic Education by the International Society of Nurses in Genetics, which is where we met, and we're going to ISON Congress in a couple weeks. She has published extensively with over 40 peer-reviewed articles and has authored and co-edited up to 12 books and book chapters. Her expertise is recognized nationally, and she is currently a consultant to the Nursing Council of New Zealand and is a member of the Expert Advisory Committee on the Educational Preparation Requirements for other levels of prescriptive authorities, such as designated and delegated. Gigi's research portfolio includes genetics and genomics education, pharmacogenomics, and antimicrobial stewardship, which she will be talking about today. So welcome, Gigi.
Thank you.
Thank you, everyone, for coming and listening to my presentation today. Coming all the way to New Zealand and being here in Prince George is really lovely. I mean, you know, people were asking, where are you going? Canada? We're in Canada, Prince George. Where's that? I said, look, of course we know where Prince George is. And so now I can tell them everything about Prince George. So it's been really lovely to be here. I actually visited because Sarah and I are doing a particular interest in genetics and genomics education and have been working together for a few years now. So it's really good to be here and see Sarah's work as well and what she's doing. I'm mainly really an educator. I started being an educator, clinician initially in nursing, and I just want to give a little history about as nurses, because we don't start as researchers, really. We start as clinicians. We're very good clinicians. And I was a clinician, and I'm actually mainly a pediatric and a neonatal nurse. And I was so good at it. I knew I was so good at it, yes, looking after the preemies, looking after the mothers and all that sort of thing. And then I decided to have a child of my own. And for some reason, when I went back to work, I would go into the unit and I would be there with the mother trying to support her. And I would be crying more than the mother is crying. And the mother would look at me and say, "Are you all right?" And I said, "Yes, I don't know what's wrong with me." I became so emotional. And it was just impossible to work with children. And I don't know what it was, but I wanted to tell that story because that was the reason why I had to get out of clinical. I had to do teaching, and I still don't understand what it is, but apparently there's so much compassion. You have so much compassion in nursing that it can sometimes be misguided. I did stay for a couple of months until one day we had this family of this preemie who was a 25-weeker who was very sick, and the whole family came, and I was the nurse, and I stood with the parents, and the grandparents came. And they started crying, so I cried. And the mother said, "Are we related to you?" I said, "No, you're not related to me. I'm just being emotional." And in nursing, you're not supposed to cry, but you did. But so that stopped my career as a clinician, but I still continue to be engaged in clinical work through my course directorship with the nurse practitioner program in our School of Nursing. And it's just sort of snowball on when you start talking about research that you realize the best research that you do actually is collaborative, looking at interprofessional and inter-country, different countries together. That's a lot more exciting than just doing your own little bit of research. But I have been involved mostly in research to do with education. At the very beginning, we actually looked at how we can develop a much better sort of framework for preparing nurses as non-medical prescribers. And it's really there that I came across a lot of the issues that we have in terms of prescribing. And one of the biggest issues that we're dealing with is teaching our nurses to prescribe antibiotics sensibly, appropriately. That's a big issue with doctors as well, but in particular nurses are still learning how to do that. And so there's not much known about the thinking process that goes through their way of decision making. And I did a study on that, and I've actually just published that paper, which I'm going to talk about a little bit. And we also have looked at, because I know there's a health psychologist here, we looked at the cognitive process. My PhD was on looking at clinical reasoning of how clinicians actually think through the risks and the benefit. Because that's the important thing when you're prescribing, is you understand what the risks are and the benefits that you're trying to do, whether it overrides the risks. And as a pharmacologist as well, I have learned that to have a therapeutic effect, every drug has to have a side effect. And sometimes 10% of the population can die of that drug. Okay, there's always that risks that you're taking, and that many of our medication can kill people. They can cause renal failure, they can cause liver failure. They affect those two organ systems because they're the organ system that clears the drug. So when we look at antibiotics, many of the nurses who come to my class said, "Gigi, can you just put antibiotics in the RN prescribers formulary, please?" And the reason why they're asking me is because Nursing Council involved me in the development of the formulary, the limited formulary for registered nurses. And the limited formulary, the registered nurses said, "We want to prescribe antibiotics. Can you put it in there?" And I said, "Well, do you realize what the risks are associated with prescribing antibiotics to begin with?" "Oh, no, they're very simple. They're used all the time," is the response I get. They're commonly prescribed in the clinical setting all the time. So I think we can manage that. So what are the risks? oh, surely there shouldn't be that much risk, is there? So I did an early research about their attitude and published that in our local journal, national journal, really in New Zealand. And I asked the question, if nurse wants to prescribe medicines, do they understand the risks that can be involved and their role in taking on that risks? So from there stemmed my discussion with colleagues from the School of Pharmacy, from the School of Medicine, from the School of Physiology. And we were asking the question, are we really teaching our prescribers the most appropriate way to use antibiotics? Do they understand microbiology enough? Do they even understand what's the difference between a gram neg and a gram pos, and why penicillin is better for a gram pos and not a gram neg? And so we had all that question, and we decided, look, it's really good to do an interprofessional, collaborative research in this area. And well, someone has to lead us. So I became the lead, not because I know a lot more about them. People that I work with, Professor Mike Thomas, who is actually the head, and I'm bringing all the names here because they're really essential to this research. So Professor Mark Thomas, who's actually an infectious disease physician who has written numerous studies on antimicrobials, have a strong belief that nurses should begin first. We should mobilize the nurses first before we can mobilize any other group. I have Dr. Amy Chen, who is also from the School of Pharmacy, who is involved with looking at health literacy, patient literacy around the use of antibiotics. And then we have Dr. Sharon Gardner, who's also a clinical pharmacist, who is actually involved with setting up AMS structure all over New Zealand. So that's sort of the background of the study. And we started applying for a grant. And this grant in particular was approved by the Health Research Council of New Zealand. And this grant was a big one to get us started. And this is just looking now at the nurses first. We're not looking at other health professionals. We're looking at the nurses first. And we're going to see whether we could start looking at the nurses and how we can mobilize them to engage more and then go from there. So we got a grant from this, and now we're on the second grant. And I've just written what we call the rebuttal for 1.5 million. And I'm keeping my fingers crossed, actually, but going to the rebuttal means you're 90% there. So that's very promising. We're going to have what we call the Health Research Project grant, and then we will get another 1.5 million for our translational grant. So that's part of how HRC is providing planning. The important thing here for this beginning grant is the involvement of junior researcher. So Jennifer Wood is a PhD student of mine, and she's involved in this project as the co-investigator. And the reason for that is because she's Māori. She's a Māori nurse. She's worked in the primary healthcare setting, and she led us into the Māori consultation process. In New Zealand, you cannot start a research project without consulting Māori. You have to have Māori, what we call responsiveness. So in consultation with Māori. So we actually consulted Māori elders 6 months before we even put the proposal together. We had to show that we have consulted the tangata whenua of the land, or they call the people of the land. So Māori leaders have a very strong role to play in the approval of this research project that we have now, because this is like a 6-year window we're looking at, and we're wanting to know how to engage more with the Māori people. I have not used so much of the Pacifica people here, although they all too are in New Zealand. We owe them a lot in terms of studies related to how we can help them achieve or have disparity. Anyway, there's disparity in the healthcare, obviously, in New Zealand. So how can we help them more? Because they're also another group that has very high, social determinants that we need to be thinking about. I haven't excluded them. The consultation is ongoing, but it is important that I acknowledge the tangata whenua of the land, and that's the reason why we've got Jen, who is our main, and then we can pass it on or look at how we can apply that to the Pacifica people. The other investigator that we've got there is Brenda Waite, and Brenda is a registered nurse, who's a charge nurse, who is the only one who in that hospital is actively involved in what we call the AMS program. And she is also my doctoral candidate. So she's part of this project, and my very esteemed colleague, Dr. Bobby Lang, who is also part of this whole initiative right at the beginning. So that's sort of the team one for this project, and I've told you the overall picture of the team for the AMS project. So the AMS is a bigger project, really. This, what I'm presenting to you, is the one that has been approved. It's now completed, and this has led us to the health research project for 1.5 million. So that's sort of how I'm putting the picture of why this study came along. So I'm trying to move this up and down. It probably doesn't do that. Or should I wait? I don't want to. No. Do you think it might?
Oh, the here. There we go.
Well done. Okay. So in 1984, I was still a young nurse at that time, no longer as young now. That was the time that we had this huge video about nurses and cleaners and marching with the bucket and, you know, all the antiseptic and saying, oh, we are in trouble. We are not going to survive another summer. We have got an increasing number of patients with MRSA. Any one of you remember that time? Probably a lot of you are too young to remember. MRSA, multiple resistant Staphylococcus aureus. And you could call it other things, but it's MRSA. That was a huge issue. So that was our first resistant antimicrobial in 1985. And I was so much part of that because the MRSA, we didn't want them in New Zealand. It was in Australia. Keep it there, please, Aussie. Don't pass it on to us. And we were very scared of it. That was a very scary time for a lot of practitioners, actually, because it painted this really awful picture about people with MRSA, multiple resistant organism. And if they have a wound, I mean, you know, you can kiss it goodbye. It's really hard to heal that. And of course, since then, we've already got 10 multiple resistant bacteria, 10 around the world. The worst is what we call the VRE, or vancomycin resistant enterococci. And when you are resistant to vancomycin, that's actually the highest form of antibiotics you can ever use. You don't use vancomycin if you can help it. So when you have VRE, that is a bit more scary now. And that's what we're seeing in New Zealand now. We're seeing a lot of this resistant microorganism. As a matter of fact, the WHO, the World Health Organization, is saying this is a global problem. This is actually a global problem, and people are not recognizing it. And the time will come that we won't have any antibiotics to treat because the resistant microorganism will just take over. The problem is we are developing, resistant microorganism is developing faster than we can find new drugs, new antibiotics. That's just, it's really the development of new antibiotics. The last time was in 1975, and it's not 2022 now. We haven't found a new compound to replace that. So is it a serious problem? Well, it is. In New Zealand, you know, we are a farming country. We use a lot of antibiotics as well for the farm, you know, for the chicken, they're in our food, you know, so this problem is not just in human health, you know, we're talking about the environment has a lot of that, and God knows how much of that spills through our food, you know, with the chicken that we eat. Anyway, I'm not trying to be the bearer of bad news, but it seemed to be a very serious problem, really. It's a global problem. And we have seen how organisms actually do mutate very quickly. In 1940, I think, when antibiotics were discovered, it only took 3 years when the first resistant organism to penicillin came about, so that's only 3-4 years. So they actually are very clever. Microorganisms, especially bacteria, are very clever. And we now know with COVID, viruses are very clever. But the thing with viruses is it's a lot harder to develop resistance because it's not as much and they're not being used as much. Sometimes it scares me that now in New Zealand, we have an available antiviral. You're not feeling well, you're feeling ill, go take some antiviral. I don't want that repeated because we're talking about antimicrobial. Could be virus, could be fungi, could be bacteria. Okay, we're talking about microorganism, and that's because that's their physiology. That's who they are. That's their morphology. They can develop resistance, and for survival, really, they don't want to all die. So they develop this resistance mutation much faster. So it is a global problem. And in New Zealand, in 2013, the experts, infectious disease physician, that's including Professor Mark Thomas, they convened together in the office of the Prime Minister of New Zealand and said, where are we here? And if we compare ourselves with Europe, Canada, United States, are we that bad? And when you compare the picture and you look at the statistics, oh, New Zealand is just a little country. No, we're not quite bad yet. But it was when we look at our community data, when we look at the rural setting, that we then realized that the usage of antibiotics is very high. So that sort of triggered something that says, no, the time is to act is now. We have to do something. That was in 2013. And they all got together, and I'm supposed they got together in this wonderful hotel to discuss about antimicrobial resistance in the, in the rural setting. What are we going to do about it? So they put out the recommendations. This is what we're going to do, and I'll just show you that in a minute. And so, we need to act. Yes, that was in 2013, and now it's 2022, nothing's happened. So it's been a long time, So now we've reconvened and we've relooked. So why is antimicrobial use of antibiotics in New Zealand high? Well, in rural areas, a lot of our children, especially Pacifica children, not so much Māori, but Pacifica children are very much prone to developing skin infection, staphylococci skin infection, and they're not easy to heal. And that could be because of their socioeconomic. They're quite deprived, it's their environment's not clean, and that could be the reason for that. But the skin infection sometimes can become so bad that they're not able to go to school, so it's seen as a problem still from that point of view. A lot of our young children develop respiratory condition. As you know, you must have heard about New Zealand home being drafty. We still have that problem right now. A lot of draft in New Zealand. So we have a lot of asthma, a lot of respiratory infection. And it seems as if every time they go to the doctor, the best way the doctor could do is give them antibiotics for that, So again, that has been looked at. Cultural practices, there's particular groups like Māori, they like to have antibiotics just in case, so they have back pocket, what we call back pocket prescribing, where the prescriber just needs to write them antibiotics as long as they've got it. They're quite happy, so there's not good understanding. So you can see that health literacy is also part of the issue that we're dealing with when we look at AMR. In our rest homes, we don't have a lot of, our professional workers there, like nurse practitioners and doctors, are not very much located in rest homes. We have a lot of caregivers. And caregivers who see patients who start having urinary tract infection, they get concerned because these patients start to manifest confusion, and they say, well, they call the doctor and said, you've got to prescribe antibiotics because they've now got confusion, and the only way to treat that is this. So again, misconception. So in rest homes, caregivers, we need to educate them, and we have a program now that is starting to educate caregivers. The other thing too that we have AMR is we're now seeing a lot of trend towards our nurse practitioners now prescribing more antibiotics than any other group. Okay, so there's this ongoing issues now that has really paved the way to us for us to look at this problem a little bit more closer. So I mean, this is a busy slide, but this is to show you that it was the mandate from the Prime Minister's office that puts us all together, all the healthcare professionals. We were asked to put together a report. So I was representing the School of Nursing. Professor Mark Thomas was presenting the School of Medicine, and Sharon Gardner was representing the clinical pharmacists. And a report was put together, which has also been published. And what they were saying is, no, we need to really act now. We need leadership. Who's going to provide the leadership? We need to be able to provide resources as well and support. You know, what are we going to do? So if we are not going to do anything about this, our vulnerable population, Māori, Pacifica, and the older people and those who are sick is going to be at risks, because we will lose the potency of these antibiotics if we have more resistant strain. Like I said, the presence of VRE in New Zealand is a bit of a concern, because that is sort of the highest form of resistant bugs that you can find. So in that report, they've concluded that we don't have a clear national leadership here. We need to start looking at that. And we actually, if we calculate the rural setting and compare it with the rural setting, I think in Canada and the United Kingdom, I'm not quite sure which country, our population actually uses more antibiotics than those populations. Although as a general, we don't, as a population in New Zealand, we do in the rural setting. We have identified that doctors and nurses, although they feel that prescribing antibiotics is easy, they actually do not understand the risks. Okay, so prescribing antibiotics to someone who's 85-year-old person who is not drinking, who may be on non-steroidal, or even not non-steroidal, just someone who's not drinking and whose renal function is not that good, you're actually putting that person at risk. But no, when we did a survey in the rest homes, 85% of those who got antibiotics were above 90. So what are we doing? You know, do they really understand? Do they really understand that the risks is more than the benefits of what they're trying to achieve? And I think that's an important question for me asking the prescriber. Do you really have to prescribe antibiotics when the healing time is only half a day or 1 day more better because you gave the antibiotics? If you didn't give the antibiotics, that person would still heal regardless. So have you looked at that? No, and that's the knowledge gap. The knowledge gap is understanding enough pathophysiology, enough microbiology to put them together and to say, hey, this is not making sense. And this is the reason why I'm not giving you antibiotics, because, you know, in the long run, the risks outweighs the benefit of me giving you this antibiotics. So that's what we found out in some of our little research that we've done for the last 3 years. We also have recognized that people are so busy. The moment you talk about antimicrobial resistance, everyone understands it. Now, when you talk about antimicrobial stewardship, everyone looks at you and said, what the heck is that? That's just the same, isn't it? Proper use of antibiotics. It's not a common language right now in New Zealand, and our practitioners are not really interested in it. They're overworked. All they want is just to do their shift, prescribe because they have to, you know, to get for that person to get better. They actually don't have time to assimilate some of the teachings around AMS and how it could benefit us for the long term. So that is what they found in that report. So what was the recommendation in this Office of the Prime Minister's report? And I'm using that because that's our national document now. So there's a very strong need to really develop a coordinated national approach everywhere, all our DHBs together. They want us to start building AMS capacity and capability, expertise in this area. And infectious disease physicians are not really the person that's well suited for that, because there's this element of who's gonna communicate to the different professionals, to the patient, and who's gonna be seeing the overall picture and the ward there, who can help us, give us some idea about how this whole collaborative effort is working. They also want to develop this, what they call the big data system, where they could bring in more data about the resistant microorganism that's in New Zealand. We still don't have that very well initiated in New Zealand. And again, they need to look at funding and research funding for this. And that's the reason why we probably got the funding, is because we're doing it at the right time. It was an opportunistic study, it's the right time to do the study, because the Office of the Prime Minister is saying, here's the money, do the work, do the study. So we were lucky that way. Okay, so we sat down with the infectious disease physician, the pharmacists who have been involved in AMS in all the DHBs, or the district health boards of New Zealand. And what we've identified is we looked at all the members of the antimicrobial stewardship group, if there was any. So of the 19 DHB, only 5 DHB had AMS. No AMS in primary care, none, zilch. And then we look at, let's look at the AMS then. It's obviously working there. It started. Who are the people there? Well, there's the doctor, there's the pharmacist. There was even the psychologist there and the counselor. Were there nurses? None, 1 or 2, no nurses. And yet, what were the nurses doing? Well, the nurses are saying, well, we understand AMR. We're doing infection prevention and control. We think that's the AMS, but that could be part of the role, but can you expand on that? So there wasn't any data that tells us that nurses were actually involved in AMS, yet they had roles in the clinical setting where they were teaching patients how to use antimicrobials, how to use antibiotics. They were actually referring to the doctor and said, no, I don't think we should continue this after 5 days. This antibiotic should be discontinued now. Thank you very much. Now that's another role that they could have put in there. The other thing too is that they're now saying too that they see the responses that these patients have to antibiotics, and they find that there's a certain population that doesn't respond well to cephalosporins. They actually, it's not the allergy thing. They actually develop massive diarrhea, even at a low dose. So there were adverse effects that were seen by nurses that wasn't documented in the AMS groups because they were not there to talk about it. So we're saying now, hang on a minute, and Mark is saying, shouldn't nurses be more engaged? Should they be more involved as members of the AMS? So Brenda, who is our representative for all the nurses, went back, did a consultation. She did a paper on that. We haven't published that one yet. Asked the nurses, 80% of the nurses are saying, we don't have time. This is a lot of work. What do you want us to do? Do you want us to monitor everyone? See all the misconception about more work. This is what we're going to do. So we're up against, okay, how do we mobilize this force? This would have been a brilliant force to mobilize, especially in New Zealand. So that was how we asked this question. And we started the activation grant asking this question: can nurses be, can we develop nurses' capabilities in leadership in use of antibiotics? So of course we know about the nurse's role, administration of medicines and monitoring and evaluation of medicines and effect. But the important thing is that nurses in New Zealand are now what we call non-medical prescribers, and they do prescribe antibiotics. So there were lots of rationale there for us doing it. And if we actually look at this current study by Sharon and her colleague, you can see, and I will just use this one. It's not, is it, can you see it very well? Because there's certain years that, so this is data. She's a pharmacist, and she went back to the data since 2016, and she looked at the non-medical prescribers' record of medicines that they actually prescribe. And I will just tell you who are the non-medical prescribers in New Zealand now. Well, we have nurse practitioners, we have registered nurse prescribers. They're not nurse practitioners, but they're registered nurse. We have pharmacists, we have midwives, we have optometrists, and this is just, the colors here. You can see that pharmacists are quite a small one, but these are our nurses. So this includes the nurse practitioners and the registered nurse prescribers who work in the community. And you can see that they prescribe the most antibiotics. So what do they prescribe the most in the data? Antibiotics and analgesics. But 60% of this was antibiotics. So they are high antibiotic prescribers. So that's one thing we need to look at. So we wanted to look at the nurses in general in New Zealand, and what they're doing right now in terms of AMS role, and do they understand that? So just a little definition of what antimicrobial stewardship mean, because AMR is just part of AMS. So in an AMS program, it is not just the optimal appropriate use of antibiotics. It's also looking at reducing antimicrobial resistance, of course, and it's also looking at the best antibiotics that should be used for a particular organism. So it's not just prescribing a broad spectrum, but really understanding why a narrow spectrum medicines is probably better than a broad spectrum antibiotic. So there's a lot of things that is included in that stewardship, but it's really knowing where this infection control, for example, comes in here, which is quite often the nurse's role, or they perceive to be the nurse's role in the clinical setting. So that was the initial exploratory study of this research, is we want to explore how nurses engaged. And the word engage means that they're actually doing something and how they participate. Then we want to ask the question, where are the gaps? What gaps do they need? What gaps of knowledge do they have? Microbiology, pharmacology, where are the gaps? So then what do they need? What support do they need? And if we then provide this for the nurses, could this help them develop leadership role as AMS steward? So the aim is we upskill them, and then we really want them to develop leadership roles, and not just be part of the AMS, but lead it. And this was actually done, this consultation was done in conjunction with infectious disease physician that was on that consultation document, because they too saw the nurses as the biggest workforce that can mobilize the AMS that is just waiting to happen. We can't wait anymore. And that's really how we asked that question. And so it is basically an exploratory study. I'm not going to bore you with the methodology. And like I said, we have to look at both Māori and non-Māori. Māori has a different process. There was a lot of the consultation that happened with Māori. Then we have to consult the Māori leaders who were nurse leaders about the questions that we need to ask. So they were quite separate process to the non-Māori. And that's what we promised we will do. So in this bigger arm of the study, we also have a big chunk, a third of that, which is just exploring Māori antimicrobial stewardship. Māori, the nurses that we interviewed here, mostly nurse practitioners who are Māori, 90% of them work in the rural setting. Okay, so that would be a big win for us if we can get that organized, because we know then that we are having a big chunk of the issue right there and then. So, what did we found? Okay, so majority of the nurses in the study, in the interview, even for Māori, they actually understand antimicrobial resistance. No doubt about that. The first thing they said is, you're talking about resistance. They have a very good understanding of it. They, maybe the detail of why microorganisms develop resistance, they don't. So if you challenge them about, tell me how they would develop resistance, for example, if you give someone an antibiotic and you say to the person that you have to take this antibiotics until it finishes, so if it's 5 days, you have to take it for 5 days. But the current evidence actually say that you do not have to finish your antibiotics now. I mean, it's changing. The whole evidence about antibiotic use have now changed. And there's a lot of studies ongoing around even treatment using antibiotics, delay healing. So all of that, do we know the current evidence? No, I don't know anything about it. Do you encourage your patient to take the antibiotics? Of course, I tell them you must take it for 7 days. You must. Even if they no longer have symptoms? Yes, of course, you have to tell them because that's how we teach them. That's how we teach the nurses. You have to tell the patient to take all the antibiotics, even if they don't feel unwell anymore. Yeah, you've been told that you must take it. Otherwise, you're gonna, all that stuff. So there were lots of misconceptions the way they were taught in the undergraduate, and they took that in, and that has never changed. So that was one that we were saying, okay, if we can capture some more of that, then we can improve the way we teach them. Okay, so they call it resistant bug, superbug, bad prescribing by doctors. Blame the doctors. When we know for a fact that in the statistic, it says it's the nurse practitioners that's prescribing more antibiotics than any other group. Don't blame the docs, but the doctors are also saying, oh yeah, that's what we do, poor doctors. So this is from Professor Mike Thomas, who said he's asked the doctors and they have accepted it. They said, we do prescribe antibiotics. Sometimes we know it's not needed because of the pressure. There's so much pressure to prescribe antibiotics, and they're very honest about it. They didn't blame the nurse, unfortunately, but that's beside the point. But our nurses didn't mean to do that. But you can see that it's not the blame, but it's saying, well, it's not really us. We've learned it from the doctors because they were our mentors when they taught us how to prescribe. And we were taught this way, okay? So how about AMS? Have you heard of AMS? And they said, that must be a new thing, but yeah, we've heard someone talk about it, but no, we haven't heard about it. Is that related to the bugs? So there's lots of narratives here, which I didn't include. They have not heard, they're confused. Of course, they're not involved. They're not a prescriber, so why would they worry about it? I don't prescribe antibiotics. And as a matter of fact, Gigi, you tell me, do your course again. I'm very time poor. I don't have $3,000 to do your course again and all of that. So the thing is, there's an element of, do we care? And there's an element of, is it my role? Is it my job? Is it my job? Maybe I don't need to worry about that on top of it. And so, in this particular research, we do converse with them and said, yes, this is coming in. You've heard about the Office of the Prime Minister. It was in the news twice last week. So I think it's time that you think about it and read about it. And we have a website, and you can be a little bit more involved. So yes, they think, yeah, we do infection control. Actually, we do a lot of infection control. And as a matter of fact, I tell the doctor what to prescribe, what antibiotic to prescribe, what's best. And how do you know that that's best? Oh, because, I've seen it. And that really works very well for skin infection. Not much data, not much evidence, learned from practice. This is what we used, and not knowing that persistent use of that antibiotic leads to antimicrobial resistance, for example, for that one particular patient. So a little bit more pharmacology they want. And they would love to be involved if they have the time. But they actually think that it's not just them, that this is a multidisciplinary, if not multi-collaborative. It has to be a multi-professional effort. In terms of Māori, they also identify the same thing, but with Māori, it came out very strong that the pressure from family to prescribe antibiotics was there. And this was some of the nurse practitioners who are Māori. They know their patient. A Māori patient come in and say, this is how they talk to me in the narratives. Okay, bro, you're just going to give me that pill, eh? That pill, so this will go away, bro. And the doctor will say, no, bro, you don't need this pill. You don't need this pill. Yes, I do. I'm going to give you a hard time if you're not going to give me that pill. So there's this element of, okay, don't give me that pill and I'm going to make your life miserable. They know each other. They know the culture. And they try to convince them, you don't need it. You try and take more, more fluids, go and have a rest, get that wound off don't put your shoes in there, get it up, get it cleaned. Yeah, it doesn't seem to go in. They just want the antibiotics. So that pressure is there, for this nurses. Okay, so that was important for Māori. So for me, moving forward for us means the consultation doesn't just happen with the nurses. We have to consult with the community, with the whānau. We have to ask the people themselves, where's this coming from? How can we help? So more engagement in the community would probably help us around this. So where to from here? So the activation grant did really activate what we want to do. And it has been giving us a lot more better sort of successful potential to get the health research grant. We have now a very strong interdisciplinary team, which is great, so we have a nurse leading it, which is me, but we have doctors and pharmacists and psychologists in this team and clinicians, so we are ready to move on ahead. And the good thing about it is we can now have a Māori arm, so we can explore that better as well into the future. So these are just my references, and I'd like to open the floor for questions. Oh, okay.
Okay, I just want to say thank you so much, Gigi, for
You're
such
welcome.
an interesting talk. And like you said, this is globally, so I think it gives us a lot to digest and a lot to think about within our own healthcare system in Canada as well. So we are, for those of you online, we're trying a bit of a new system here. So we have a mic that I'm going to run around, and hopefully then you can hear better the questions from the audience. So hopefully we don't have too many technical glitches.
Any question from the room first? Oh, there's the question.
Okay, we'll try. I'll just paraphrase here. Do you want to go ahead?
Yeah, so it's kind of like, first off, thanks for the great presentation today. But it's kind of a jumble of questions I had. The first one was like, in Canada, like there's been a huge shift towards like telehealth. I'm not sure how it is in like especially for a rural setting. I'm not sure how it is in New Zealand, but to an extent, I think the change that have applied for like a patient and healthcare provider setting. So as you mentioned, like well, for some people where they have a connection with the doctor already, so even though they know they want the antibiotic, it becomes easier. But we still do have that interaction. But over with a like telehealth setting, it becomes more hard because if the doctor doesn't give it to you, you might even have the option to just go to another one and another one. There's more having a family doctor, right?
Yeah.
Can have that conversation with you.
Yeah.
So how is that in New Zealand?
Yeah, so I'll answer about the telehealth first, because we've done a study on that one, but I wasn't as involved in that one as my friend, Dr. Michelle Honey. Telehealth in New Zealand has taken off about 15 years ago, so you're right, because we have so many rural settings in New Zealand to begin with. Broadband was an issue. Whatever connection it is, it's really slow. And I have been in one of those. So consultation can actually happen, in that sort of setting. And we didn't ask specifically about antibiotic prescribing at that time, but what actually happened is if the patient connects with the doctor through that telehealth, so as long as the patient has a connection to broadband, they can actually connect to the doctor and the nurse practitioner who's manning that clinic, because sometimes it's just a nurse practitioner or a nurse. Sometimes there's even no nurse practitioner. So the nurse then connects to the hospital setting where there's a doctor there. And that's sort of how that thing happen in New Zealand. Lately, we have been trying to improve connection to broadband in the rural setting with a little bit more success now. And so there is that element now that nurse practitioners need to go out there and work in the rural setting. But we only, believe it or not, our nurse practitioner education happened in 2000, and we only have 360 nurse practitioners in New Zealand because it's a very rigorous process, and these people don't like to go to the rural setting. They actually want to stay in the city now. And as a matter of fact, there's a lot more of them that's going to the rest homes and which is good, which is what you want. So that's sort of the situation.
So does that make it harder to, because you don't have just nurse practitioners wanting to go into these communities and then telehealth being somewhat dominant in the field, does it make it is it one of the big challenges for antimicrobial stewardship?
Oh, huge, especially in the primary care setting. It is. So that's part of our question is what resources and what support system can we provide to make it happen, to make this AMS happen in the rural setting. That's part of the question. And I think when we do the translational grant, which is after 2023, 24, 25 is when we will start. Me saying that, I might not be leading that, but maybe I'm hoping that Mark Thomas will come in. And we're hoping to develop an antimicrobial stewardship center wherein we acknowledge a lot more people in the process. Yeah, so there's this plan, this ongoing plan.
So maybe I can kind of follow up a little bit, because when I think of disparities in our health system, particularly with rural and remote communities or indigenous populations, I always think of it as kind of a lack of access or a lack or access to treatments. But in this case, it kind of seems what you're saying is there's more likely that they will be prescribed antibiotics. Could you maybe just kind of elaborate on a little more on the reason why that may be?
Why
in rural versus urban settings?
Yes, that why they're prescribed more
More
antibiotics in the rural setting. Partly the context of New Zealand. So in New Zealand, in the rural area, I don't know, probably the same here in Canada. All the doctors are gone by 2:30. I don't know, the same in Canada. There's hardly any clinicians at 2:30. Everyone wants to go either. We're such an outdoorsy person. Where's the doctor? Just a lot of people actually from the United States, they're doctor, they come in as locum because they want to do, what do you call that, surfing? So the doctors are surfing about 3:30. So that's a bit of a laugh. That might be a joke, but partly could be because the doctors are in a hurry to get out, at that time, and I know it. And the patients, when they come, they usually come in, especially for Māori people, they come in really looking sick. Their cough is like you would think, oh, you need to give antibiotics. That was one of the reasons that was seen, that they look a lot more sicker. And that could be why they're prescribing more. Like I said, there's a lot more skin condition. And there's also the incidence in New Zealand of rheumatic fever. I don't know if you've heard about that, wherein it starts with the strep throat. And Maori people are very sensitive to that. So they start with the strep throat. If they're not treated with antibiotics straight away, that could develop into a rheumatic heart disease. And that scares a lot of prescribers, because in the rural setting, you send them home on a Friday and you don't know what's going to happen on a Saturday, Sunday. Again, that would increase prescribing. But there's numerous costs. And I think Steve has done a study on that. Dr. Steve Ritchie is one of the infectious disease physicians around, because he works with the GPs. So he looks at ways where they could reduce this kind of prescribing without having to be scared that, you can go home and you're all right. So that's another one. Yeah.
So for this initial study, you had a fairly small cohort, and you said about 90% were from rural communities?
For the Māori.
Oh,
Yeah, for the NPs we recruited. They were from the rural communities, yeah.
So in your larger study, are you going to look at this more like
Yes.
differences
Yeah,
between
so-
rural and urban areas?
Yes, so in the next study that we have been just gone for rebuttal, we are going to recruit 580 registered nurses on all hospitals and DHBs. And we were also going to recruit 360 nurse practitioners and registered nurse prescribers. So we're hoping to get a good cohort sample. Yeah. Mhm.
Is there a question online? No? Okay, so the microphone's not working, so we're gonna stick
That's
with
all right.
this. We'll try and maybe paraphrase a little bit
Yeah.
for people to hear.
I just had a comment, just from experience, I'm a registered nurse also, and I work for Personal Health Authority, actually. And one thing that I also noticed is the lack of access to testing for like strep, for example, because that testing is not quick. That testing turnaround time in remote communities have to send out the
Yeah.
specimen could potentially be like a week and a half, 2. So you're making decisions, things like us, might be tuberculosis treated with antibiotics. Whereas in the city, you can get that result within 24 hours. So the doc might wait to make a decision to prescribe antibiotics in that case, and then if it comes back negative, then it's not like
So,
let's do a different approach. But
so you prescribe antibiotics because of that, just to, in case, yeah?
I think that's
Yeah.
what happens
Yeah.
because of that.
Yeah.
There's no
Yeah.
rule out, whereas
So-
in the city you can.
So the study that I have published, I thought I actually put it here. I studied NPs and their decision making. And one of the biggest problems with prescribing antibiotics, in the sense that you've actually brought up, is called diagnostic uncertainty. And you're not supposed to prescribe broad spectrum straight away, really. That will encourage resistance. But because of that diagnostic uncertainty, they will have to, because it takes 3 days before you can get the resistance, study done. The sensitivity and resistance study done. So that could be the reason why. What Dr. Steve Ritchie is trying to do is convince the doctors and some of the prescribers that not every condition is treated, and identified specific conditions that needs treatment. Because I think what's happening, because we had so much availability of antibiotics, we just seem to assume that antibiotics is the answer to that. And that's what I mean by the knowledge gap. I think all of us, including me, what are the situations that you can then say, I'm not going to prescribe, I'm going to hold on with the presence of rheumatic fever? I mean, can you hold on? It's your responsibility if this child's going to develop rheumatic fever, wherein giving this child early antibiotic treatment is actually the best approach. So all of that is not easy to sort of, they're not compatible, isn't it? You've got a very serious condition that requires antibiotics, and yet on one hand, you're told not to treat until you're absolutely sure it is that. So diagnostic uncertainty is true for both doctors and nurses. And what we're trying to establish in this antimicrobial center is to provide more studies around how we can identify conditions that require early treatment, because we have treatment around meningitis that has been missed and the patient have died. And that really scares GPs. Doctors are scared of that. They don't want to be responsible for that death. So Steve, on the other hand, is doing the role that I'm doing, and he's doing the doctors. The doctors are not convinced and said, what will we do in this particular case? What are the guidelines? What is the best antibiotics to use? And can we sort of know for sure that we're holding on to this treatment and nothing's going to go wrong? Yeah.
Yeah, I just want to say too, also the risk is greater, like in rural remote communities to wait, because if you're waiting and that person's health starts to really dip, you have to consider shipping them out to higher levels of care, which can create further delays. So it's just like always like greater risks in that approach.
Yeah. So there were a lot of that was outlined by the nurse practitioners that we interviewed in the study. And, again, the diagnostic uncertainty, where are the resources, where are the support, where are the clinical guidelines, our clinical guidelines that is actually detailed enough that the doctor can say, okay, I'll do this one first before I do that step, We do not have a clinical guideline clear enough to provide that sort of help in that kind of situation. So that's a very good question. Thank you.
So I actually am kind of like taking your question because as you said, I think it's really beautiful work and really a work that really kind of unfolds, like you have a resistance, you have a literacy, you have beliefs about medication, and you have like the context of practices that you just described. And all of that, I feel like come into like a big nexus of like, okay, now I have like, there's the pressure of like developing resistance, but there's the care of that person in that moment. And as a practitioner and nurse practitioner, they're overworked, as you mentioned. Like it's a profession that is, they're sent in a location that they don't have a lot of resources, and themselves they don't have often a lot of resources. So you just compound a lot of maybe sometimes the burden of stewardship onto a profession that is having a big burden of care too. And I was wondering, in these studies, and also considering in New Zealand's the mandate, the national mandate, do you also in like reporting back on your study saying, hey, we definitely need better stewardship, but to be able to provide stewardship, we need to have context under which our practitioner have the ability to get trained to improve their literacy. So there's context that, so I don't know how you jump.
Yeah, that's a very good point. So part of our impact statement in this study is saying, how will this impact on education, research, and practice? So educational institutions through me and Professor Mark Thomas and Dr. Stewardship, we're all really strongly involved with the education and the use of antibiotics at the Faculty of Medical and Health Science. So we're hoping that we'll be able to disseminate this to other schools of medicines, and there's only 2 schools of medicine, but there's 17 schools of nursing, and how we can change the curriculum. That's another thing Sarah and I were talking about, genetics and genomic competency adding in, but looking at AMS competency, how we can add that on. I mean, you know, like the world is just changing, and we really need to review that curriculum and say, are this curriculum fit for purpose? Are we still educating our nurses fit for purpose in 10, 15 years time? And probably not. When you look at COVID and the amount of pressure that put on the nurses, well, they shouldn't, but you know, but they were under a lot of pressure. That tells us that we have not prepared our nurses for understanding emerging infectious diseases. And we're going to have some more of them. They're going to come. COVID is just the beginning. And yet we don't have an infectious disease paper that would give nurses some kind of skills around how to handle. You know, we were scrambling for what's the most proper mask to wear. And, you know, they were like astronauts, weren't they, at the beginning? It was so uncomfortable. My sister used to come home and have lines on her face. And she said, I hate this life, you know? So, but was it necessary? I mean, that's the kind of thing, I don't know, but we are missing something. And AMS is just part of those. How are we going to teach that? How are we going to develop that? How are we going to provide that knowledge? And I hope to come back here maybe in 2 years' time and tell you. And we're also looking at patient study, like I explained to you before. That's a separate cohort when we're looking at Asian people, Asian meaning me, myself, and many other Chinese that's lump in there, unfortunately for now, and Māori and Pacifica, and look at this patient's responses to antibiotics. So it's an overall, so we're hoping to really launch this whole thing nationwide, interprofessional, and I'm just proud to be leading it because I'm a nurse, you know, like, so this is not a project that is normally led by nurses, but that's to show you that many doctors have acknowledged that this is a role that nurses really can play in the future. Because of what we already do.
Yes, I've been thinking of, because I remember this antibiotic resistance and how alarming it was. And everybody was up in arms, and we seemed to kind of forget about it or become complacent. So you brought up COVID, and you know, hopefully we keep learning from this, and the alarm doesn't go away, and that we really have, you know, the backing of the government and practitioners like yourself researchers like yourself
Yeah.
to keep these issues kind of in the forefront.
Thank you, Kendra. No, we're very lucky that we've got the government backing us on this stuff.
Is there any other questions for right now? Well, if not, I would just like to say we're so happy that you have been able to visit us at UMBC, and we definitely hope that you come back in
In
2
2
years or
years.
3 years and share what you have found out.
Yes, yeah, that will be an exciting one. I think this is a bigger number and we will soon be able to say what we're going to do. Yeah.
And just for everybody that is here on campus, I want to invite you. We're having a little social with Dr. Lim at the Thirsty Moose. So if you can drop by, please do. You can ask her more questions or keep the conversation
Or you might like to
going.
come to New Zealand or do some kind
Ask
of
her about
postdoc.
New
Yeah.
Zealand. Yes.
I'll be happy to talk about postdoc and anyone who might have that intention to collaborative research. Yeah.
Okay.
Thank you
Again,
so much, Kendra.
Thank you.
Thank you, guys. Thank you.